All right, everyone. Thank you so much for joining. Good afternoon or morning, depending on where you are at. This is the April CFHA Community Conversation, which we hold monthly on a topic of your choice. These really come up from the community of practice and what folks are interested in talking about. And this month, we're going to be talking about the power of community-based roles. Um, these are really encouraged to be group discussions and questions. Are not necessarily a webinar format or anything like that. These are really hopefully, generate a lot of good discussion and questions from you all. So I'm excited that you're here. If you feel comfortable putting cameras on and jumping in and coming off mute, that's awesome for us and our participants and our panelists. But you can, of course, also put questions and stuff in the chat as well. So the topic today is community-based roles in integrated care. And there's a lot of different names for those. I'd be interested to hear kind of what you all call them in your organizations. I've heard paraprofessionals. I've heard subclinical roles. I've heard community-based roles. And maybe there's some others as well. But we're talking about people in roles such as peer support workers, community health workers, sometimes doulas are included in that. And they're increasing participation on an integrated care team with primary care docs and behavioral health professionals. So we have three awesome super participants with us today. So I'll let them introduce themselves. Maybe Zoe, we want to start with you. Just tell us just a little bit about your role and why you decided to join today.
Hello, everyone. My name is Zoe Martinez. I am a behavioral health navigator here at St. Christopher's Hospital. We're located in Philadelphia, Pennsylvania. Within my role, I want to say it's a very diverse role because I'm also connected to three of our main clinics, our Adolescent Teen Center, our Special Needs Department, and also our Urban Child and Development Team, which is called our CUC. So the role is specifically like being that middle person to bridge the gap between behavioral health services and connecting them also with resources within the community or even within their school and the school district. So I'm connecting with the parent, the caregiver, the co-worker, with the therapist, the psychiatry team. So it's
Mm-hmm.
like I'm that middle connecting piece for our families and our patients that we serve.
Awesome. That's great. I'm excited to have you here today. Thank you. Patty, how about you?
I'm Patti Robinson, and so I at this point, in the past I was a BHC in a migrant stream clinic in a rural area, and I worked with a what we came to call a behavioral health consultant assistant.
Mm.
So BHCA, whose background was as a medical assistant, and she did some of the things that Zoe does and other things that were kind of unique to her position. Right now, I'm a trainer and consultant. I've worked with a lot of systems that are trying to figure out the puzzle uh,
Mm-hmm.
and unlocking the potential of using community support workers, whatever that might mean, and whatever label they might be known as in their unique system or country or region, because they have tremendous potential. So I am also at present a consultant on some grants exploring training community support workers in focused acceptance and commitment therapy, and kind of linking them with BHCs that can support their work and using this powerful approach to people in the community that are underserved, such as Latinx people in southern Texas as one population that have uncontrolled diabetes, but also veterans that are, uh, less connected and looking at the potential of these roles with chronic pain and with diabetes, and
Mhm.
doing some, exploration of what competency training means for this group, what
Right.
what we can establish. So it's a great field,
Hmm.
huge potential.
Wonderful. Thank you. Thank you for being with us. And Desiree, do you want to introduce yourself and your role?
Sure. My name is Desirae Rivers. I am a behavioral health care manager with a company called Air Supports, and we are integrated in that we utilize the collaborative care model. So I am the BHCM, and then I work with peer support specialist, a psychiatric consultant, and the patient's primary care provider. So we're very integrated in the clinical setting as far as their primary care. And our peer support specialists will do a lot of the things that Zoe and Patty already mentioned, as, as far as like connecting patients to supports. In this particular iteration of integrated care, it's more oriented to substance use support, so groups,
Hmm.
um, and helping them find their way in the recovery community. And then we also provide um, some things that are sort of impacting those health related social needs that impact their use. And then we do therapy as well. And that's how we perform integrated care here.
Great. Thank you so much. Thanks for to all of you for being here. I forgot to mention if you are on the call, if you can put your role and your health center or your organization in the chat. That will be super helpful to us as participants, as all of us are wanting to, get to know each other and kind of understand where folks are coming from. I'm located in Chicago and I do a lot of work with our FQHCs in Illinois, to help them integrate their teams and care. And I'll tell you, this is a huge area of discussion, integrating newish roles to the team. Great. Thank you for dropping your name and your role in the chat. I would love to hear from the group if you feel so inclined, kind of why you joined, what your kind of questions are about these roles, or how it's going as you integrate them on your teams. Think about just thinking about that for the discussion today would be super helpful, just so that we are making sure we address people's questions, and using each other as resources. I think, and that's great. I can see people's info coming in into the chat. Looks like a great mix. So I think one of the main question, I mean, maybe it's not one of the main questions, but it's how my brain works, is in sort of a practical way of like, how do we make this work for everyone, right? And I think one of the main questions that seems to always come up when thinking about integrating peers, and Desiree and I have done some work together at ERA as well. When we talk about peers specifically, because I also have done a lot of work with that role in substance use treatment, is I find it difficult to understand who's doing what sometimes between the behavioral health licensed maybe or trained person and then the person with lived experience, even though that there's not always that distinction, right? Somebody who has a license has lived experience, somebody, right? But in an organization, I do think it's our responsibility to sort of define those roles for the people in them and for the patients. So maybe Zoe, I can put you on the spot in terms of how you think about your role or how you were trained to work alongside a behavioral health teammate.
Coming from, I guess, from like a healthcare background, it's always like meeting the patient or the family where they are for starters, and just having that open communication with the provider and the entire team, because this was actually something that I was mentioning in my previous meeting today. Like when we're all tackling social determinants of health and we're meeting with the
Yeah.
families during like clinic, or we're doing an intake, whether it's in person or via like on, virtual or a phone conference, from our team, who is that delegated to? Because these questions, they get asked over and over again throughout the session. So it's like
Yes.
just to take some of the stress off the patient and the family because they're being asked the same questions. And a lot of times we're meeting these children for traumatic experiences. So you don't
Right.
want them to keep reliving these things over and over again. So it's more so like, okay, like if I'm coming in from the behavioral health side of it and I'm navigating, my goal is like the educational background of the patient. Like what resources do they need? Are they getting any supports in the classroom? Who are they connected to within the community? Like, is there any past history? So like that's what I dive into. And then like our community health work routine, like, is there any disparities within the home from utilities to homelessness to transportation? Like we all just had like a nice sit down of like, okay, like if there's six moving parts, what's the responsibility of each of us? And then
Hmm.
of course, like maybe like at the end of the week, we all come back and we collaborate on what we learned from this patient and how we're going to continue outreach and do our follow-ups.
Awesome. Awesome. So a lot of collaboration, a lot of communication with your team, and
Mhm.
then what can we do to not burden the patient with the same questions over and over as much as we can?
Yes.
A
Mhm.
thoughtful approach. That's great. Patty, any thoughts on role clarity?
You know, it's, I think that we have our support workers in all kinds of positions, sometimes in the clinic, sometimes outside the clinic, sometimes in the clinic and outside the clinic. And so we start with where are they? And
Hmm.
what kind of support do they need? And because I think where they are sometimes leaves them vulnerable. And that has been a real concern. And when we look at the research, what we know is they do face a lot of stress related to limited resources to refer to. You know, they know what to do, but then the access isn't there, and they want to stay in scope, and yet often the person they're sitting with uh, does have suicidal ideation. And so, I mean, that it's a lot of pressure on this
Hmm.
role. And I would say the better definition of the role, um, and with attention to this meeting their needs, their support is something we should take on. Um, so that we have them in a consistent way. The other thing is, I think we need to look at funding
Hmm.
their role, because sometimes, their funding is coming from someplace other than primary care. So maybe coming from an NGO and maybe grant funded, and that funding can go up and down. And we don't want to lose those people. So um, I think we need to define the role and look at it broadly. What do they do? How are they supported?
Hmm.
And what kind of training do they need that would be available from people in integrated care? And also, how can we expand their scope? Because there's no way for us to meet the needs in the world or just in America with the workforce we have that have
Right.
a license. And so, how do we further train, invest in them, and link them so that they are adequately supported? We
Hmm.
know they make a difference. We have research that says we should do this. Back
Hmm.
in 2015, the United States Air Force embarked on a um, study, 2-year study, looking at um, they wanted to shift the front door to mental health care to primary care. So they wanted everybody that they served to go to primary care for mental health substance use concerns first, with a few exceptions. And they didn't have any more money to invest in hiring more people to increase their BHCs in primary care. So they took some mental health providers out of their mental health service to kind of strengthen their BHC base, but they also took what they called 4 Charlies. These are community support workers. They are people that in deployment often do the work of a social worker or psychologist because they're in the forward operating base. So these people, when they put them in, they measured outcomes for 1 year without the enrichment. They added these in the second year and they looked at outcomes, and they had a small clinic, a medium clinic, and a large clinic. And in the medium-sized clinic, there two of their BHCs left at the start of the study. And these 4 Charlies, these mid-level providers, did a fantastic job of enhancing access. So that was one of the accidental findings. But, overall, we need them, and they benefit the population served because they improve access. However, we use them, and we need to figure out how to measure that
Right.
routinely.
Right. Thank you. Thank you. If anyone in the gallery, I'll say, has ideas on how you've defined roles, we would love to hear that, or questions about that. I think, Desiree, do you want to talk a little bit about, I think your experience on this is super valuable because it gets very tricky, I think, especially in the model you're working in.
Yes. So there's a lot of overlap. Um, and especially as we are sharing patients and having sort of that triangle where the BHCM and the peer work in the same section. And
Hmm.
we are often communicating with the providers and the psychiatric consultant in the same meetings. I think a thing that AIR does well is that um, all of the peers are trained as certified peer uh,
Hmm.
recovery. So they have a particular curriculum that they learn in that within that piece. And then when we talk, we have our team trainings that kind of emphasize, like, even though you may be working with a patient who is suicidal or a patient who has some trauma and they are consistently like trauma dumping, this is how you as a peer can handle that. And so it kind of allows for that delineation of like, this is what I'm comfortable with, this is where my role sort of begins and ends. And then it also allows for the peer to know when to say, okay, I'm hearing you. This is more of the BHCM's role, and I can support you here and also get you to the more appropriate professional for what you have going on. So I think that's how we do it. And I think a lot of it is like Zoe was saying earlier, some like a lot of team communication, making sure that patients don't have to continuously repeat the things that are happening to them. And so a lot of our patients, I will share with a peer and we'll do bi-weekly alternating appointments. And in between those appointments, the peer and I will communicate about what happened at their last appointment so that we don't have this, lack of communication or communication barrier. So that the circle is kind of, closed by the time I next meet with the patient.
Yeah, I think I think as you're talking, right, I think it's a good thing that the peers, I almost experience them as almost like reluctant to hear too much about a certain topic. And they get a little kind of like, taken aback. And in some ways, that's maybe an indication that they're worried that they're going out of scope. Right. And of course, they can't control what a patient is going to tell them, and the patient might feel comfortable, and that's why they're sharing. But having a behavioral health supervisor or having someone on the team that can be that support for the peer to know, okay, this needs a referral, this needs maybe not necessarily a higher level of care, but different care than going outside that role is, I think, really safe for both the peer and the patient. People agree with that? Yeah. Someone is asking, thank you, Liz, for the question. How are you billing for the PSS time with the patient? Are you, as the COCM BHCM, including your consult minutes with the peer in your monthly billing? Desiree, maybe that's a question for you, or I don't know if others can.
So for us, any of the so the initial evaluation or diagnostic evaluation performed with all three of us, the patient, the peer, and I, that is not included in the collaborative care minutes, but anything outside of that. So when the peer meets with them sort of ad hoc, that is included in the collaborative care minutes. And the joint sessions that we have are also um, calculated in the collaborative care minutes. The only things that are not are any clinical services. For instance, if I'm doing one-on-one psychotherapy, that would not be counted in the collaborative care minutes. But any health-related social needs, any follow-up with the providers, those things done by either the PSS or myself, those would be counted as collaborative care minutes.
Great. Thank you. Thanks. That was very helpful. So let's maybe transition a little bit on talking about recruiting. Like what makes a good peer support worker, or what makes someone maybe fit for integrated care, community health worker? How do you all think about that? And honestly, this can be anyone in the room. It doesn't have to just be the super participants. It can be anyone in the room that might want to weigh in on that. What has been working for you in terms of recruiting?
When you say recruiting, are you referring to recruiting peers or patients?
Sure.
Oh, okay.
Any of the roles, like the support roles.
From what I've observed, there's a lot of emphasizing like lived experience as far as recruiting and just advising because because like with the kind of lived experience that a person would have, just letting them know that that's going to be we're going to more heavily rely on references rather than background checks, and I think that
Hmm.
tends to help. So that's what I've seen as far as recruitment.
Lived experience.
We deal with a lot of, like, that's a lot of the criteria that we go by is, of course, lived experience. Like, if you have any training or education or you've gone to school for certain things, that's also a plus, but it's more so learning the community that you serve. We
Yeah.
have a lot of, like, we're currently like looking for another psychiatrist for our hospital, and we've had a lot of candidates, but it just seems like it's not a good mesh because they're like, well, this is a high crime area. And I'm like, well, this is Philadelphia. It's like we are in
Hmm.
North Philadelphia. So it's like you really have to be in tune with the families that you're coming across. Like you're not
Yes.
going to get a parent who's going to be calm and mild mannered all the time. Like you're going to get that mom who comes in with 5 children and they all have to be seen by different specialty teams. So they're going to be overwhelmed, and you have to know how to engage with that parent to make sure that all of their needs are being met. And
Yes.
also connecting with mom because she needs resources for herself. And that's something that I see where it's like I have a lot of life experience, but it's like you have to learn how to engage with everybody. So it's like you have a provider who comes in and they're throwing off all of these medical terms. So it's like, okay, I go in and I break this down for mom. I'll give her a summary of like what your next steps are, because when you're getting your epic summary, they're not giving you all that information. So it's just meeting them like where they are and just using the skills that you have, not just as an advocate, but if you're a mom, hone into those skills. Like if you're a single parent, hone into those skills. Like we get a lot of grandparents who are raising children. So it's like you see everything here. So it's just taking into mind that you have to use all of your skills, not just your education, because we have the textbook knowledge, but it's also you got to have some street smarts when you're using and coming into like engaging with our families, because like I said, we're not in a rural or a suburban area. We're in the heart of the city. And one thing that I noticed like a week or two ago, like a lot of my patients are starting to come from other counties, and they're not eligible for our behavioral health services because they have a different insurance, or the residential area is too far out. So like that's one of the barriers that we're actually focusing on now, because we have an insurance team that helps us navigate for connection to therapy. But if you don't have the proper state insurance, it's like, what do we do from there? So that's
Yeah.
one barrier that we're currently working on now within our practice.
Yeah, Zoe, those are such awesome points. Like you have to be able to hang. And that's probably like regardless of role, you have to know the community you're walking into and be able to serve those people and be able to sort of have the emotional grounding to know how to meet those folks. That's a great point. And Travis, you have some great comments in the chat. Do you feel interested in coming off mute to share more about your thoughts on this? And if not, I can read them. Okay, no worries. So Travis's comment is around self-starter, which I think is really cool. Um, Looking for something from a recruitment standpoint around someone that can probably has initiative. And he's saying, or Travis is saying, choosing self-starting over, and maybe someone without experience in primary care over someone with a lot of experience, but maybe isn't as taking as much initiative. So I think that's a really good point. Patty, any thoughts on this?
Yeah, and again, it's so context specific. Who are you hiring for what? And
Hmm.
but a general principle would just be use use the workforce that's available. And, certainly echo what Zoe and Desiree said about you want people that are experts on that community. So that probably means that they live in that community.
Hmm.
And they can be cultural brokers, language brokers for the team. That many team members may not live in that community and have very limited experience. So I think let's see, workforce use who you have. I've seen some countries like or in country like San Francisco, they used a lot of people, sanctuary city, five primary languages. They're using people coming in from other countries.
Mm.
Often they have backgrounds in healthcare, but they have no license or anything. And so the original work by Tom Bodenheimer at San Francisco General, demonstrated how powerful they were with taking newly arrived people to a big city like San Francisco and getting them connected to the care and services that they need. So use the workforce you have. And I think also recruiting uh, probably needs to include uh, some statement about career progression, that they can
Hmm.
start, but that this is a role that the organization is going to invest in. There's going to be support for continuing professional development. And that I think is going to get more people interested and more people with, potentially leadership skills that would lead them to progress towards being trainers for other people coming because we will need to expand this workforce.
Hmm.
So we want, yeah, to be thinking. I One other thought is this, which I've seen in several systems. One in Australia right now, there's a group that of community support workers that serve family members that have some type of health issue that really requires a lot from the family. So it might be a child on the spectrum. It might be an adult caring for a parent with dementia. It could be uh, the mother of a single mother of someone after a first break. So but they're in that care role. And so they have this program, and it's such a cool thing. It goes up to 12 months, but it could just be 2 or 3 visits with these community support workers, but it's all laid out and includes support groups and lots of skill training. But they are recruiting from their graduates to fill positions.
Mm-hmm.
And and their graduates are also invited to become a part of an advisory board that looks at ways to improve this program. I just felt like it had so many total quality improvement kinds of things to it that um, help us address recruiting
Yeah.
into
Oh,
there.
that's great. That's great. Thank you. Thank you all for chiming in on that. And there's been some questions in the chat, which is really great to see. So Laurel has a question. Laurel, if you want to come off mute and ask, or would you like me to read it? I'm happy to go either way.
Sure, I'm happy to ask. Thank you all
Thank
so
you.
much for your really fantastic insights. I'm curious, you know, in a lot of cases, people are really interested in implementing these models, but getting people to try them out and work with maybe a new workforce can be difficult. And so I'm curious if you have any reflections about implementation and, who have you seen leading these initiatives and what are some of the kind of talking points that have convinced folks to say, yes, this is really worth giving this a try. And then any reflections you have on lessons learned or barriers to implementation. Thank you.
That's a great question. Thank you. Any initial thoughts on that from anybody?
I do. Or no, go ahead, Desiree,
No, it's
please.
fun. I was just gonna say for the implementation piece, or it seems like from my just reflections in the last year, because ours is sort of a new or a pilot program. It seems like a lot of the PCPs sort of champion it. And
Mm,
I find that like a barrier to implementation is for leadership proving effectiveness or proving value. Does our organization need this service?
yeah.
Is this going to work for our patients or the population that we serve? And traditionally, the collaborative care model has some evidence, but the evidence base is predominantly with depression and mood disorders that are not, and it's not really going to be applicable to some of the more serious mental illnesses. So really proving that it's a valuable thing for a setting to have is going to be a barrier because of the evidence-backed data being primarily oriented to mood disorder. But in this, just and I noticed someone in the comments or the chat was talking about um, presenting opportunities. I think that has also helped, just being able to present the data from our pilot program and talk with more providers who have seen the effectiveness of what we're doing. So I hope that answers your question.
I think, I mean, reimbursement's a huge issue, right? I mean, like if you can't bill for the role, fortunately, fee for service, if you cannot bill for the role, it's a much harder sell, I think, to executive leadership. And state by state, those roles I think are becoming more popular and interested on the state level to find pathways to reimbursement. But I think it's the case with case managers, peers, community health workers, right? Finding those ways that those services can be billable. Another point of uh, success has been around if an organization is building value-based care system or interested in moving into value-based care, these roles can be so helpful in terms of enablement, getting patients from the community who are lost to care back to into engaged in care and primary care, especially folks that are maybe street-based or they're not, they're unhoused or they don't have phones, right? So if you're working with a population that's really difficult to find, and yet you are responsible for those panels of patients, community-based roles are gold, right? Because those are folks that can be doing outreach and that can really be bringing folks back into care. And that is, I think, a way to an argument that you could make to leadership of the value of those roles from a value-based care standpoint, or even not fee for service. But ED follow-ups are really, really difficult, and those are roles that can, really enhance those visits. I think it's a great question because I think everybody talks about how wonderful they are to the care team clinically, but I think making the business case is a little bit more difficult sometimes. Any thoughts on that from you, Patty? Yes, I
Um,
see your comment.
I was just going to say, I've been involved with New Zealand for about a decade, and they started on a countrywide effort about 7 years ago to bring two new roles to primary care. One very similar to the BHC role, and the other what they call the health coach. It's
Hmm.
unlicensed community support worker, maybe with lived experience, cultural expertise, and maybe not. Um, and so we had the opportunity. I mean, one of the first decisions, I think, in a system is how are we going to train these people to do what they're going to do? And there's the question, if we're going to bring two roles, do we train them together or do we train them separately? And so I think it's costly not to train them together from the
Hmm.
beginning because they need to develop those relationships and that sense of I've got your back and we're in this together, and it's not about you do this and I do this and stay in your lane. It's more about we're going to help each other. So it's that team relationship. And New Zealand has documented the importance of that kind of flavor, um,
Hmm.
uh, where particularly on the South Island, they were working really hard after the basic training for the hip and health coach. Health improvement practitioner is BHC in New Zealand. So I say hip, sometimes meaning health improvement practitioner, but they immediately on South Island, the organizations there started ongoing professional development that included both the hip and health coach. So they were trained together, they were part of teams, and then they partnered with community and with their practices or clinic staff. And um, I, it's just amazing what the health coaches were doing there, and it's was also reflected in better retention. So I think
Hmm.
training together, training health community support workers to be generalists, to feel
Yeah.
like they can. This is going to demonstrate the business case. If your training includes you're helping with chronic conditions, you're helping with lifestyle behaviors, you're helping with pain, anxiety. You have been trained on protocols that help you um, do something on the front line, and pass it back and forth with a BHC is because that a lot of times that person's going to need your, even if you involve the BHC in their care, they may need you on a longer term basis to check in with them.
Hmm. Great. Thank you. Amanda, I see a question from you. Did you want to ask or add anything to it?
No, it's just I'm new to the concept of community-based roles, and so there were just a lot of different roles that came to mind with that particular verbiage or title. And one of the thoughts I had,
Amanda, we can hear you very, very faintly.
okay, one,
Maybe your headphones are, I can, Okay, I'm sorry about that. I apologize. Um,
There you go. Can you hear me
oh,
better now?
yeah, yeah, that's
Okay,
great.
sorry, I have a new system, so I
Yeah,
can't switch to different
no
things.
problem.
No, I was just saying that I'm new to the community-based roles, that like word for it. So I was just trying to think about like with the people that I talk to who would fit into that role. So I was just thinking about how often I communicate with like school professionals in the school or even non-professionals and kind of how they would fit into this idea. I know the funding part gets kind of difficult because that kind of the funding siloed, right? It's like
Hmm.
we're, bill for care, like we bill only insurance, and a lot of the schooling's funding is primarily through the government and those types of things. So I don't know if that would be like a different category or just your perspectives on that.
You're in a pediatric clinic?
I am, yes.
Okay, and you have school staff. I'm looking at this. So like, would school staff fall into the category of community-based roles?
Yeah, or it sounds like from what you guys are describing, it's usually an individual that's employed like by the healthcare
Yes.
system. Yeah, versus like somebody that's in another system that we might work with.
Yes, that's my gut, but I'm curious from Zoe or Desiree. I don't know if you do any work with school-based or if you have to, okay, Zoe's nodding, or like you maybe have to collaborate with school. This might not be the same category of professionals, but yeah, maybe talk about collaboration a little bit.
It's a lot of collaboration because I also like assist our patients who may need IEP reviews and things of that nature. And
Hmm.
we just actually spoke of how the billing would work as far as our community health workers, because they're more so out in the field and they're going to some of these meetings with our parents at the school. So it's like I've collaborated with everyone from the one-on-one advocate in the classroom to the school district to educational law teams. It's like it's all a collaborative. It's like an agency. That's how I think about it. Like we are a working agency because different schools require different documentation and information. Like I have one family where the child is enrolled in a Catholic school, but they don't recognize the IEP or the services that the child needs because of like the whole religious background connected to the school. So I had to get an educational lawyer to assist the parent, and then I got one of our educational advocates. They're pretty well known, the ARC program. We have connected with them like to help the family like get through all of those steps of making sure that the child is getting the right needs. So actually as of fall, they're being transitioned to a different school.
Hmm.
So it's like all of those connecting parts, but definitely different agencies because like you have at one point we did have a lot of the like guidance counselors and different teams come into the hospital like to work with us in our behavioral health team or like our special needs team, but it's gotten to the point where our BHNs and our CHWs are more so boots on the ground within the school district to make sure that all those connections are being made.
That's incredible. That's so cool. That is, so you're collaborating with everybody as a patient advocate, essentially, and connecting the systems together. That's very cool. Amanda, is that helpful, or is there more to that question?
Yeah, it is helpful because I feel like so I'm a behavioral health consultant, so I've just kind of been doing a lot of that. And fortunately, like their organization allows me to do that and not, have to worry about the billing part of things. But, it probably would make more sense for us to have somebody that helps with coordinating that care just so I can, focus. I mean, I love that work. I love
Yeah.
connecting with community members, but is that you know, I guess not the best use of my time. Do you know what
I
I'm
know what
trying
you're
to
trying to
say?
say. I know what you're trying to
Yeah.
say. Like you probably are held under productivity standards and billing and all of that. So, yeah, that's a great question. And Zoe, what a cool that's like awesome that we were able to then hear all the work you're doing in the schools. It's amazing. Cool. Any other thoughts on that? Or Patty or Desiree, have you worked in a school system at all in that way?
I I would just add, Amanda, maybe one way to kind of grow in the direction of, having more resources and more collaboration with your community. Maybe, just have a once a month Zoom meeting to talk about your role and their roles and ways you can work together and invite opinion leaders in your clinic to attend these just so that they can hear the collaboration going on and talk about ways to kind of grow it. I know you're part of the Philadelphia Federation.
I'm with St. Christopher's
Yeah.
Hospital for Children, so yeah. And like
Yeah.
we're connected with Philadelphia Family Voices, who are also advocates for like a lot of our children with mental health disabilities or learning disabilities, just as far as like bridging the gap so they get all of those supportive services they need, either in home or at school or like with a wraparound program. But like to chime in what you just added to, Pat, like I also connect with like a lot of our churches. Like
Mm,
if we do like our like roundtable meetings that we have here on campus on site, and then we also have like, your regular neighborhood community meetings and things of that nature. Like I try to connect with them at least twice a month just to say, hey, like these are some of the services that we have, like whether you're connected to the hospital or not, like you can always reach out to someone here at our team to try and help them figure some things out along the way.
Excellent. Yeah.
Yeah, I love that you brought up the the churches parks. I actually just went to it was my first time going to the Christian Association of Psychological Studies conference. And there's a group of people that have developed this like it's called Church Care or Churches That Care or something curriculum. I don't know if you guys have heard of it, but it's the idea is to train like people in the church not to do like clinical work necessarily, but we're not going to be able to address the mental health crisis with just treating clinicians, right? So it's
mhm.
another way to like train other people in the community to do some of that work, which I just thought was awesome.
Yeah,
So
very cool. Yeah, this is awesome. This opened up like such a cool area of discussion. And there's some great comments or some resources Laurel just put in the chat. Chanel said building relationships with community organizations outside of the network is the main role of the peers in their last position. So helping to build probably those referral partnerships. Michelle said local police organizations as well. I've seen that too. So this is great. So in our last few minutes here, maybe if somebody has another question, please throw it in the chat or if you want to come off mute. But I thought maybe we could share just patient impact. Kind of if you have any like quick stories about the value of these roles to patients. If you've got anything that comes off the top of your head of how helpful or powerful maybe the roles can be, or what kinds of things that those roles are helping with. Desiree, not to put you on the spot, but maybe you've got something in the ways that how the peers have helped patients, or how you think of that role.
Yeah, sure. So we have a patient who has been um, unhoused for a really, really long time, living in a shelter, and had some substance use. And that's how he sort of got introduced to introduced to ERA. And within the time that he's worked with us, and this has been a year. He has completed a program with our peers assistants. It's a welding program. He
Hmm.
recently graduated that, and he's gotten into a program that supports housing. So he has his own apartment, and he is because of Janice. Janice is one of our peer support specialists. She has gotten him involved with a program that will provide all of the furniture for him. And so he often will say that he looks at us as his aunts, his aunts, and he talks with us about things that he doesn't really get a chance to talk about with any other people in his life. So I think that is a huge impact, and I think of the short amount of time that his life has turned it around, and I think the majority of that is due to Janice, and so that's an impact that I feel like is really needed.
Yeah, great. That's amazing. That's a wonderful story. Thank you. Any others that come to mind?
I'll just tell a story of a patient that we served as a team, and the BHC assistant played a critical role. And this was a person that had suffered lots of mental health problems throughout her life, and it became known to our clinic when she came for a specialty kind of consult. We had someone that would come to rural healthcare every once in a while, and then became fixated with having a health problem. And so she called our clinic, 9 or 10 times a day, and just was really suffering in a violent relationship, not consistently housed, and not consistently just supported with basic resources. And we formed a welcome team, and the behavioral health consultant assistant, Ernestina, was kind of the head of that team. And so she would initiate calls to this person every morning, every afternoon, just asking her to not call the clinic so that we could call her
Mm,
and check on her. And that worked fantastically. And then we saw her 2 or 3 times a week, anytime she could get a ride to the clinic. Actually, Ernesty would greet her in the waiting room, bring her back, give her a hug, pass her off to one of 4 or 5 other people that always had 5 minutes for her. And over the course of months, she moved to kind of weekly or twice a month appointments. Uh, uh, about a year in, she got lucky and got connected with a church that helped her get safe housing, where she cooked some for her um, board, and she felt so proud of herself. And so it was the BHC uh, assistant role was huge in
hmm
making this happen.
hmm
And this person moved to a whole new level of living that she was pleased with. Yeah.
Yeah, that's so wonderful. That's wonderful. Thank you. I have just a short one. I worked with a community health worker with a patient that was having chronic back issues and kept coming to the PCP for that. It turns out that she was sleeping on a cracked bed frame for many, many months or a very long time. And he was able to work with some local community organizations and find a bed frame for her, went to the house, delivered it, put it together for her. And what sounds like a simple fix, it's actually not easy to do all that work, really, really helped this patient's quality of life and improved some of her chronic pain. So just some really cool stuff that happens, I think, outside the office. And some of these roles are going to be so helpful. So, and so you've already shared all the amazing work that you're doing for people. So we got those stories. Any last comments before we end? You can come off mute or just throw something in the chat if you have anything or if our panelists have anything. Okay. All right. Well, y'all can keep sharing comments or questions through the email group, but I just want to thank Patty, Zoe, and Desiree. Thank you so much for joining us today and sharing your experience. Thanks everyone on the call who participated and just are here to listen. We really appreciate you. And look out for our next monthly community conversation with CFHA. Hope you all have a great rest of your day. Thank you so much.
Thank you.
Bye.
Bye.